Hello everyone. I may finish the PowerPoint in this lecture. I'm going to try to, at least, so hopefully this will be the last one. I just wanted to show you some things I added this is what I added to the first lecture. I just circled some common themes to help you remember which receptors are which. When it comes to the cyclic GMP receptors that are linked to guanylyl cyclase, think of vasodilators, right? BNP, ANP, these natriuretic peptides that act on the kidney and the blood vessels, and then I forget what EDRF stands for, epithelial-derived relaxing factor, maybe, and then nitric oxide. They're all vasodilators. For GQ-coupled receptors that perform IP3, phospholipase C, that whole pathway, they are a lot of vasoconstrictors, right? Angiotensin 2, ADH, and alpha-1 receptors are all vasoconstrictors, and they're all the same pathway too. When it comes to the receptor tyrosine kinases, think growth factors, right? What else did I add? Okay, I added this picture from First Aid for thyroid hormone synthesis because I like it a lot better than this one. As a reminder, over here in the lumen is like the colloid, and thyroglobulin is actually the molecule that kind of holds on to T3 and T4. And then right before T3 and T4 are released into circulation, there are proteases that kind of chop them off. And then the thyroglobulin and MIT and DIT are recycled and used. All right. A lot of this should be review. So I'm going to try to get her done here. Okay, adrenal cortex. We are talking about salt, sugar, sex, right? GFR. Salt, sugar, sex, the deeper you go, the sweeter it gets. It's a classic mnemonic to remember the layers of the adrenal cortex. Zona glomerulosa, zona fasciculata, and zona reticularis. Salt refers to mineralocorticoids like aldosterone that controls, volume and sodium. Sugar refers to, glucocorticoids, mainly cortisol, and it regulates blood sugar, which is why that's part of the mnemonic. Even though cortisol does a ton of different things, right? And then sex refers to the zona reticularis because it is the site of production of what is called weak androgens. And you can think of these as precursor androgens. You might see terms like DHEA or androstenedione. And usually they will travel in the blood to peripheral tissues and the testes and ovaries. And at that point, they're converted to kind of the big guns like testosterone and estrogen, if you want to think about it like that. Now, the zona reticularis during development, if there's a certain genetic disease like enzyme deficiencies, which we'll talk about later, these weak androgens can cause, for instance, if there's overproduction of weak androgens from the zona reticularis, it can cause what's called virilization in females. So girls can be born with an enlarged clitoris, and that's basically what virilization means. And then another enzyme deficiency can also cause things like newborns to be born with like pseudohermaphroditism. So just some interesting notes about that. All right, so another picture of it. So the deeper you go, the sweeter it gets. And then you should all remember the adrenal medulla, don't forget, is underneath all of that. Maybe it could be like salt, sugar, sex, and sympathetics, right? Oh, and that's a good reminder. I wanted to correct something. I don't think this is right. Blood pressure and blood volume, yes, right? Aldosterone controls that, and cortisol, right? Aldosterone, cortisol, and aldosterone. Sexual function, I would say this should be zona reticularis. Sympathetic response, I would say that should be adrenal medulla. All right. Okay, histology, where you have purple stuff and pink stuff and white stuff. And that's all I ever see. The good news is, if you can't identify things on histology from an H&E stain and boards, it doesn't really matter as long as you can figure out stuff from the question stem. But they love histology of the adrenal cortex because this is like dark and that's light and that's more pink. Alright, so G here, zona glomerulosa, zona fasciculata, zona reticularis, and the adrenal medulla down here, right? As we go from outside to inside. Okay, cholesterol pathway is kind of a B, alright, but this should simplify things, and that's why I like videos like Pathoma and Physio, especially Pathoma. You know, he does a good job of just simplifying it. So we're in the adrenal cortex, right? We have, let's say we have ACTH stimulating this first step. Stimulates cholesterol desmolase. It's also called side chain cleavage enzyme. That's the rate limiting step of cholesterol, of the steroidogenesis, or steroid synthesis pathways. Cholesterol is converted to pregnenolone, and then from there, pregnenolone serves as the precursor, for kind of really all three of these pathways. Well, real quick though, remember that technically the zona glomerulosa is under control of the renin, angiotensin, aldosterone system. So technically it would be like angiotensin 2 that activates that. Anyway, they are all steroid hormones, so they all are derived from cholesterol, right? And they're all derived from pregnenolone. Okay, so if we're in the zona glomerulosa, if we want to produce aldosterone, which is a strong mineralocorticoid, we first need to form a weak mineralocorticoid, and that is performed via the enzyme 21-hydroxylase, and then we need an additional enzyme 11-hydroxylase to make strong mineralocorticoids. Now, if we're going to shunt this pregnenolone over to be used for synthesis of cortisol and or sex steroids, we need 17-hydroxylase. So that's what these numbers represent. If we're in the zona fasciculata, we also use 21 and 11-hydroxylase to make cortisol. If we're in the zona reticularis, we need 17-hydroxylase for it to be shunted over, and then we can make our weak androgens, right, like DHEA and etc. The reason this pathway is important, and I don't think I'm going to test you over it, I just want to introduce you to the idea, is because of something called congenital adrenal hyperplasia. And that is kind of what I was referring to at the beginning of this lecture, is when newborns are born with ambiguous genitalia. And it can get really confusing because depending whether this 21 hydroxylase is knocked out, or 11 hydroxylase is knocked out, or 17 hydroxylase is knocked out, you can get slightly different presentations. But regardless, all three of them have adrenal hyperplasia. So that means regardless whether it's 21, 11, or 17, you're going to have an increase in ACTH, which actually causes the hyperplasia. If you want to study this more, you can. It's good to kind of test yourself, because then you can really understand aldosterone, cortisol, the sex steroids, and androgens. I don't think I really need to say anything more other than 21 hydroxylase deficiency is the most common. And I'll explain that one because that one makes the most sense, I think. Okay, so let's say we knock out 21 hydroxylase. That means all the pregnenolone will be shunted this way. And it's 21 hydroxylase blocked here. So if this is blocked, it's all going to get shunted over to make androgens. And that's the reason that in 21 hydroxylase deficiency, if you are a female, right, you can be born with virilization. And that's due to the effect of androgens acting on the clitoris. So you get an enlarged clitoris. This is the pathway in full, and it's super fun. Okay, where else have you seen this? Cholesterol desmolase. Ah, there's angiotensin 2. Okay, that makes sense. So ACTH still does affect the zona glomerulosa. Yes, it does. But you can't make aldosterone, or it does not activate the synthesis of aldosterone, right? Just the precursors up here. Aldosterone synthase is only activated by angiotensin 2. Okay, so where else have you seen this? You should be thinking in the gonads. Same enzyme family, but in the case of the gonads, LH is the main stimulator, not ACTH, right? Keep that straight. This is what I was referring to earlier, congenital adrenal hyperplasia. When you do learn this in med school, I included this screenshot here from first aid because it's important to remember the common themes, no matter which of these is knocked out. They will all have hyperpigmentation because of the increased MSH, right, at POMC. And they're all going to have low cortisol, right? No matter which of these is blocked, they're going to have low cortisol, and that's why we have high ACTH, and that's why both adrenal glands are enlarged, because the ACTH is bombarding those adrenal glands because it's sensing there's low cortisol, right? And this is a good mnemonic for whenever you learn it. If the deficient enzyme starts with 17 hydroxylase, it causes hypertension. And that's because the pathway is shunted this way and you have too much aldosterone. If the deficient enzyme ends in 1, either 21 hydroxylase or 11, it causes virilization in females, and that's because of the reason I talked about earlier. The pathway is shunted over toward the production of steroids. Okay, aldosterone. You should already know all about aldosterone. I just wanted to compare and contrast the metabolic abnormalities seen in Addison's disease versus primary hyperaldosteronism. So remember, in Addison's disease, we have low aldosterone and we have low cortisol. And these two diseases are kind of inverse to each other. If you see this kind of triad slash, what's tetrad of symptoms, be on the lookout for this in test questions. This constellation of symptoms, hypertension, hypokalemia, metabolic alkalosis, and hypernatremia, it has to be some type of hyperaldosteronism. And that's because you know the functions of aldosterone. So this all makes sense. You reabsorb too much sodium and water, you get hypertension. You secrete or excrete too much potassium, you get hypokalemia. You excrete too much hydrogen, you will get alkalosis. The classic example, and maybe the most common, is called Conn syndrome, and that's a tumor, an adrenal adenoma that secretes aldosterone. So these in Conn syndrome or primary hyperaldosteronism would be the opposite, metabolic abnormalities. So think about what the opposite would be in Addison's disease. We'd have hypotension, hyperkalemia, metabolic acidosis, and hyponatremia. Theoretically, you don't always see all those, but yeah, it's good to compare and contrast those. And in Addison's disease, cortisol is affected. Not so much here. It's just high aldosterone that I know of. And this is what I talked about, and I included these screenshots to get you to start thinking about the why, right? Think about the why. Because. Always ask why, and you will be very successful. Like, what is the mechanism? Just for your sake, this would be a case of something called low renin hypertension. Low renin hypertension. That's because the aldosterone is coming from the tumor, and then it's going back. The effects of the aldosterone are going back to inhibit renin secretion. If you have any questions about this, ask me, because that'll probably be a test question. Okay. And then I included the same type of, hopefully will stimulate the same type of thinking in Addison's disease. What is the hypoglycemia caused by? What is all of these things caused by? Like, what's the mechanism going on here? Cortisol, this from first aid, cortisol is a big fib, and it goes over all the different mechanisms. I already highlighted the alpha-1, that's important. You get increased sensitivity to the thing that binds alpha-1, so norepinephrine and epinephrine. I talked about this. Cortisol is a counter-regulatory hormone. It causes insulin resistance, and that's the same thing that happens in what? Type 2 diabetes. Increased insulin resistance. Similar mechanism there. Decreased glucose utilization, and that kind of goes with that counter-regulatory hormone effect. Increased gluconeogenesis, etc. I talked about this. Decreased collagen synthesis, and 3 kind of high-yield things about its effect as an anti-inflammatory agent. It inhibits phospholipase A2, and phospholipase A2 is the first step in the arachidonic acid pathway. So that's the pathway that you get a ton of immune mediators from, prostaglandins, leukotrienes. Hopefully you are familiar with this from immunology. I'm not sure if you remember this from immunology, but there's the leukocyte migration thing, and like the rolling and adhesion, and that's how it gets to the target tissues. Well, cortisol actually inhibits that process at the adhesion step. So you end up with high white blood cell count because the blood cells can't actually get to the tissues, which in this case, it's not a good thing, right? It blocks histamine release and blocks IL-2 production. I would say this is pretty high yield, and then the IL-2 is pretty high yield. Just FYI, I doubt I'm going to get this detailed on the test, but just letting you know. And then decrease in osteoblast activity. Let's see. I think I'm good there. You already know all this stuff. Summed up here, the summation. Okay, and this is Cushing's. So what is the mechanism for each of the things in Cushing's? And remember I said the most common cause overall is exogenous Cushing's. The most common endogenous cause is Cushing's disease. Okay. And this is a good summary from first aid. Okay, so the zona glomerulosa is primarily regulated by angiotensin II. Hopefully you remember this stuff, right? Chromaffin cells, preganglionic sympathetic fibers. Okay, which of the following are derived from cholesterol? Think about it for a second. Definitely sex hormones. Not this, right? Because that's from tyrosine. All adrenocortical hormones. So both B and C. Remember, aldosterone, cortisol, all of it, they're still, all steroid hormones from cholesterol. Cholesterol is converted to pregnenolone, and pregnenolone is used for the synthesis of all three. Which of the following does the adrenal cortex produce? Not this or this. It's adrenal medulla. Yes, both B and D. Cortisol and aldosterone. Selective destruction of the zona glomerulosa would produce a deficiency of which hormone? GFR, salt, sugar, sex, salt, aldosterone, the mineralocorticoid. This is produced in the zona reticularis. This is the zona fasciculata. This is the zona reticularis. Which of the following zones are primarily regulated by ACTH? Primarily regulated. So it is zona fasciculata and the zona reticularis. Primary regulation here, angiotensin II, and the primary regulation here is luteinizing hormone. Theca interna cells in females, Leydig cells in males. They're homologs of each other. But remember, both ACTH and LH activate the enzyme that converts cholesterol to pregnenolone. And that makes sense because, I forgot I included that. Let's fill in the blank. Conversion of cholesterol to pregnenolone. Difference in adrenal cortex, I just talked about that. It's activated by ACTH here, and in the gonads it's activated by LH. Okay, I copy and pasted the question from today about the woman with Cushing's disease, just to give an example of how many different things you can ask just from one question. Okay, so Cushing's disease, the most likely cause of the hirsutism is, and this is kind of like male facial hair patterns and stuff like that, I think. increased stimulation of the zona reticularis, because adrenal androgens are going to be elevated in Cushing disease because we have high ACTH. The ACTH increases the production of adrenal androgens from the zona reticularis, as well as the obvious increase in cortisol at the zona fasciculata. Okay, what is the cause of her hyperglycemia? And that's due to the counter-regulatory effect of cortisol, the increase in gluconeogenesis. Most likely cause of her hypertension is the upregulation of alpha-1 receptors, the increased sensitivity of norepinephrine, epinephrine, right? Which of the following series of lab values would be correct? So these questions, when you're doing these questions, write down the lab values first. So figure out the answer first and cover up the choices, and then look at the answers. And if you're not quite sure, you can start narrowing it down by crossing out ones that you know aren't right. So we have Cushing's disease. So we have high ACTH, which means A has to be wrong, right? We have Cushing's disease, so we know we have high cortisol, so we know D has to be wrong. Cushing disease is an ACTH pituitary tumor, ACTH secreting pituitary tumor. So we're going to have, oh crap, okay, let's pretend this arrow is a down arrow. So the answer is B, because we know we have high ACTH, we have high cortisol. The cortisol goes back to the hypothalamus and inhibits the release of CRH, so we're going to have actually low CRH. The only time all three would be increased is if we had a corticotropin-releasing hormone secreting tumor in the hypothalamus, right? And, a time we might have all three decreases, like a hypophysectomy or like a removal of the hypothalamus. Okay, Addison disease is an example of primary, within the organ, adrenal insufficiency. But what key difference would be present in secondary adrenal insufficiency? So I'll let you think about that for a second. So if the problem was there, that means the primary problem is a deficiency of ACTH from the anterior pituitary. So the difference is a lot of the symptoms would be similar to Addison's disease, but the difference, they would have no pigmentation, right? Because there's a deficiency of ACTH, right? And MSH, and ACTH, their cleavage is related, right, from POMC. And they would not exhibit the hyperkalemia or metabolic acidosis or volume contraction, and that's because aldosterone levels are normal. And that makes sense, right? Because the problem is not in the adrenal gland where aldosterone is produced. The problem is at the pituitary. This summary table, don't memorize this table. It's just for your tools and your toolkit. This stuff is a headache when 21 hydroxylase deficiency, 17 hydroxylase. So use that little first aid mnemonic whenever you learn it. It'll help. Screw it, let's do it. Let's do the gonads. Testes. Testes are boring. Boring, boring, boring. I don't even need to talk about it. This is just a reminder of the Leydig and Sertoli cells. You know, don't forget spermatogenesis over here too. These are the things that it produces, and when it's stimulated by what? FSH. Leydig cells, when it's stimulated by LH, produces these things. Just FYI, testosterone goes into the blood, goes to peripheral tissue, and there's a 5-alpha reductase that converts testosterone to dihydrotestosterone. That's a good thing to be aware of. Okay, what do Leydig cells produce? Testosterone. Sertoli cells, one of the things they produce is androgen binding globulin. If we wanted to go back, this is Sertoli cells, right? This is also the Sertoli cells. Well, actually, semen. Maybe it's from the prostate gland or somewhere else. Sperm comes from the Sertoli cells, but I'm not sure. I forget where the semen comes from. Seminiferous tubules or prostate gland. I don't know. Estrogen comes from, what is that? The granulosa cells, right? Granulosa cells. Oestrogen. Oestrogen. From the oocytes. Okay, GnRH comes from the hypothalamus, right? I already said that. Granulosa cells. Testosterone comes from Leydig cells. Alright, let's do a quick word on the female reproductive stuff. I spend most of our time talking about the menstrual cycle. Estradiol, keep in mind, obviously important in puberty, and regarding menstruation, it's responsible for the follicular phase, and progesterone, the luteal phase. And those phases are referring to the ovarian stuff that's going on, okay? So the menstrual cycle is all about baby preparation. So always kind of put yourself in the seat of the ovary or the endometrium and think, what should happen here if I were to prepare myself for implantation? And if you always ask yourself that question, you'll never get a question wrong. I don't know, never, but it's a decent strategy. So keep in mind the different things that are happening in the ovary versus the uterus. The ovary is the site of production of the actual egg, right? Ovaries. The uterus, or the endometrium, is the site of preparation for implantation. So let's focus first on ovulatory control, right over here. Ovulation happens approximately at day 14, right? If day 0, or let's stick with this terminology. If day -14 is menses, approximately, but it can vary, approximately 14 days later is ovulation, and then approximately 14 days after ovulation, if the egg is not fertilized, then you have menses again, right? And then that cycle repeats itself. The follicular phase can vary very widely between individuals. Now, this is high yield AF. High yield AF. Okay, LH surge. As you can see, the orange, just follow that guy right there. The LH surge happens, and this is what kind of stimulates the ovulation. But before that, right at about days 12 to 14, so immediately before the LH surge, you'll notice is a peak of estrogen. And at this point is when we have estrogen acting in a manner that resembles positive feedback. whereas all other times of the cycle, estrogen and progesterone are acting via negative feedback. Estrogen is kind of like a special one right here for just this time, and that's what causes the LH surge. And the mechanism's kind of interesting. How it does this, it actually, and this is a great example of what I talked about in the first lecture, it upregulates GnRH receptors on the anterior pituitary, which means there's going to be more of these guys on the pituitary, right? Upregulation. And then that means there's going to be more LH, FSH. As you can see, they both go up, but that LH surge is the famous one, because that's what stimulates the dispelling of the egg, right? Peaks approximately 1 day before ovulation. What else do I want to say? This increase in temperature right here is due to progesterone. I don't know why they like you to know that, but they do. And just FYI, when you talk about when an egg is fertilized and pregnancy does happen, progesterone is, when in doubt, say progesterone for your answer if you don't know the reason for a certain effect in pregnant women. Progesterone does a lot. And in this case, luteal phase, increase in temperatures due to progesterone. Mittelschmerz is the pain associated with ovulation. Can mimic appendicitis because it's usually a right lower quadrant pain. When in doubt, always order a pregnancy test on the test question and in real life. If you see weird presentations from females age 10 to 60. Let's focus on the uterus, shall we? The stages of the uterus and endometrial lining are different, right? The follicular, luteal phase, that in reference to what's happening at the level of the ovary. So before ovulation, right? Menses from the previous cycle. Then there's something called the proliferative phase. And estrogen is mainly responsible for that. Right? You can see it growing, proliferating. Now, once we have ovulation, okay, let's say ovulation traveling down, and the egg sits right here, because this would be vagina, this would be cervix, the egg's sitting there ready to be fertilized, right? We're at this point in the timeline, right here. Now, if you come up to this chart, you will notice in the red, yes, okay, good. Notice this kind of inverse thing happening. In the red, we have estrogen starting to decrease, but in the green, we have progesterone starting to take over. And the reason for that is once ovulation happens, the corpus luteum forms, and the corpus luteum is a site for a lot of progesterone. So we see an increase in progesterone, and during the secretory phase, which starts immediately after ovulation, that is mostly under the control of progesterone. And the secretory phase, it's kind of gross, but just think about it, secreting a lot of like juices around here, getting it like nice and juicy because it's ready for implantation. Because implantation happens, 6 to 7 days after fertilization. So if we have fertilization here and implantation happens 6 days later, we want the endometrium to be like nice and juicy and ready. And the red here is due to the outgrowth of spiral arteries, So there's a lot of arterial growth. There's lots of good stuff to make a comfortable place for the little blastocyst to implant. However, if there is no fertilization, we have an immediate withdrawal in progesterone and estrogen, and that is what actually causes the breakdown of these arteries and the breakdown of the uterine lining, which you see in menses. I always think it has to be kind of disappointing for endometrium, like every month. You know, it's like gets all ready and then it just doesn't happen. I guess it's just nature's way of being prepared. I don't know. Okay, this is good compare contrast in male versus female. It's a good thing to end on heading into the reproductive section with Chidozi. Okay, learning objectives. I will refine / add to these, but this is what I have for now. It has been a pleasure getting to know you guys and teaching you. If there's an eval sent out after this course, please let me know what you liked, what you didn't like, what kind of things stuck with your learning style, what didn't work with your learning style, and thank you for being my guinea pig class. And start a Roth IRA. Can't afford to lose out on that compound interest.